Multidisciplinary centers are a resource for NET patients. And what do I mean by that? Treatment for patients should be local because NET disease is not as frequent or as common as lung cancer, breast cancer, or other neoplastic diseases. The expertise is not in those local communities. NET centers can assist the local practitioner, the local care provider, in developing a care plan that's more than just somatostatin analogs. So NET centers can help the patient understand the disease better and develop a more comprehensive approach as what's next when the somatostatin analogs aren't enough.
Multidisciplinary teams for NETs, I think, are critical. This is a cancer that, even more than others, requires input from multiple disciplines.
At our multidisciplinary tumor board, we have medical oncologists, surgical oncologists, we have interventional radiologists, we have part of our nuclear medicine team, we have pathologists, we have our social workers, we have our geneticists, our nurses also attend. And the reason that we have so many people involved is because it really is a multidisciplinary way of treating patients. And really, we're not treating just the tumor, we're treating the patient. So it's important to have the social worker there and the geneticist there because it's not just about treating the cancer, it's also about making sure that the cost isn't going to be prohibitory for our patients. It's important to make sure that we know if the patient has risk for other genetic syndromes. So we want to make sure our genetics team is involved. We want to make sure that our surgeons are all discussing and deciding what the best surgical intervention is. We want to make sure that our radiologists and our nuclear medicine physicians are really weighing in on whether we've done all of the imaging and staging that we need to do. And then our medical oncologists are there to help kind of put it all together and figure out what the overarching plan is going to be. So the multidisciplinary approach is incredibly important, especially in tumors that are so rare, such as neuroendocrine tumors.
This comes up a lot when we're working with community oncologists. Patients will often say, well, I feel badly having you also on my team in addition to my community oncologist. What if my community oncologist doesn't like that? And I'll say, we work and partner with your community oncologists all the time, and we are happy to have them on the team, and you need both of us.
Perhaps one of the most important core components of that multidisciplinary team was that there would be multidisciplinary meetings or tumor boards held on a frequent basis where there would be a group of individuals with significant expertise and interest in neuroendocrine tumors brought together to discuss each new patient coming through the clinic.
Typically, the way it's set up is we bring images and pathology slides and we put them up on the screen and we discuss them. So first, somebody will present the case. For example, they will say this is a 55-year-old man who presented with abdominal pain and was incidentally found on colonoscopy to have a neuroendocrine tumor. Then we'll show the imaging. So we can show the colonoscopy imaging and we can also show the radiology imaging. So CT scans, MRIs, dotatate scans, and we'll discuss what we're seeing on the board. We'll discuss what we're seeing in the imaging. Then we'll discuss the pathology. So now the pathologist will say, these are the pictures of the actual biopsy. This is what we're looking at. This is how we came to this diagnosis. Then after that, we'll talk about what stage the patient is. We'll talk about what the treatment options are. So if it's someone where we found local disease, where it's just in one area, we'll talk about surgery, and the surgeons will talk about the surgical approach they want to use. The surgeons sometimes share different surgical techniques, and some will say, oh, I would approach from this way, while someone else says, maybe I would approach from this way, and they have a discussion on what the safest way to do the surgery would be. Then after that, we discuss whether chemotherapy is necessary or hormone therapy is necessary or PRRT is necessary, and the oncologist weighs in. Then at the end of the tumor board, we have a plan that's comprehensive after we've gone over all of the data that we have for the patient. Sometimes we say we need more testing or we need more imaging, and then the person who's coordinating the tumor board at whatever institution that may be writes out a plan and then sends it to everybody who attended the tumor board and also those who weren't able to attend, so everyone knows the plan of these patients moving forward. That way, if there's ever any questions, we have it documented and we've communicated it to all of the important people on our team.
It's really valuable to get expertise and input from all of these different doctors as they all can bring different perspectives. It's often a really valuable discussion, and I think that patients get the best care that way. And I think it also removes some egos. It requires some humility to be able to ask for help. And I think patients, you want doctors that are willing to do that.